Hello, and welcome back to our podcast, The Boss Ravioli Queens. We are Boss Lady Amy,
Nicole Ravioli,
and Jasmine the Queen.
And we are healthcare workers who decided we are going to spill all the ravioli on the ins and outs of working in healthcare.
This isn't your usual podcast. If you came here for health and beauty tips, you're gonna be disappointed because we are gonna get messy.
Every other week, we will feature a different topic that dives into the not-so-talked-about, taboo, and just plain underbelly of healthcare. We will talk about what it's like being a caregiver outside of work and all the struggles that come with it. Just trying to be normal, everyday people.
On that note, let's
get
messy.
Warning, this podcast includes profane language, crude humor, mature subjects, and possible talk of bodily fluids. This may not be suitable for listeners under the age of 18. So this episode is called Right to the Source. This is a very exciting episode. We have our first guest ever today. My sister, Lady T.
Yay!
Welcome.
Thank you. I'm so happy to be here.
So in this episode, we are going to be talking about MCOs. We have mentioned it a little bit before in previous episodes. MCOs, if you don't remember, managed care organizations. The reason why we have Lady T on with us today is because she is going to be talking all about it since she worked at one for 4 years.
Oh, 4.5. Mm-hmm.
Oh,
Sorry.
Me too. No, I'm just kidding. So, yeah, talk about it.
Yeah, you can take over. Take the floor.
Take over. Okay, so MCOs, as Boss Lady Amy said, managed care organizations. I did work at one for 4.5 years, which I can't believe. It was a very chaotic time in my life. We'll just say that. I just want to be clear on that. I have not worked at an MCO for well over a year now. I did get a different job. But I went into it and I really wanted to learn to case manage. And so that was kind of like the thing to like teach me. So I have a degree in sociology, which is very close to social work, but it's not social work. So I'm not actually, I always joke I'm a poser. I was a poser social worker. Because I wasn't actually certified, right? But I did all the things. So I worked at an MCO in our state. There's 5 MCOs in the state of Wisconsin. And the one that I worked at, it was the largest, and I believe it's still the largest. And the coverage area is almost the entire state. With the exception of like 4 counties. So, we do long-term care. And so that's what we did. So, we facilitated the family care benefit. And family care, how much have y'all talked about it? Maybe not too much?
So
not too much yet.
we know what family care is from our little
Yeah.
side of it, but
Yeah.
from your side it's different.
So family care, I guess, right, this is like a lesson. You guys
Yeah.
always give lessons in this stuff.
Yeah, a little bit, like a little background on like what it is.
Yeah, so family care, it is a benefit under Medicaid. And so Medicaid is the state insurance. And all states, it looks a little different for every state, but all states have Medicaid. And Medicaid is like a really big umbrella. And then there's lots and lots of different insurance plans, I guess, to simplify it, right? Make it easy. Insurance plans, quote unquote, underneath that umbrella of Medicaid. So family care is just one of those insurance plans. And so we did the family care benefit at the MCO. And that's for people who need long-term care. And you all have talked about long-term care, right? Mm-hmm. And that's really self-explanatory. It's just basically folks that for whatever reason, like it's not a point in time, they are going to need long-term care supports for their entire life usually. So family care, like I said, Medicaid, and people would come to us, and there's like 2 kind of pieces of eligibility for that particular program. So people had to have one functional eligibility, which means you have some sort of diagnosis, or you have some sort of need, or you have something in the medical documentation, right, that like supports that. So functional, and there's certain things that maybe you can or can't do for yourself, right? Number 2 is the financial piece, and that's pretty standard, I think, like those 2 different things for all of the different types of programs under Medicaid, but the financial piece. So for family care specifically in our state, you cannot have more than $2,000 in assets. And so that gets really chaotic because a lot of times people will come to the program and like maybe they're married to somebody and they have like a house or they have a car or a vehicle, whatever. It's really interesting. You have to like prove with that documentation that you only have like 2,000 or less in assets. So they give you like 9 months to basically disentangle yourself from those things. So if it's like, oh, I'm on the title for a house, but I'm still married, they like redo the paperwork. So the spouse puts that only themselves.
Oh, that's
right?
crazy.
Yeah. So it is.
Lot,
and so just like, like legally, those are the things that you have to do. But anyway, so that's kind of the really super like high level basic. The types of individuals that family care supports, and again, every program is different. There's different waivers, there's different things, but the eligibility, there's 3 target populations that family care serves. And these folks, the queens, they take care of all 3 of them. So kind of the
we do.
Yeah, caregivers, love it. Thank you for what you do, for real. Like the world would not run without you all. But anyway, so those 3 populations. Are you guys feeling the feel?
Yes.
It's so sweet.
Well, for real. So, okay, so the 3 populations, and this is like state languaging. This is like what they talk about in the contract. So number 1 is frail elder, and again, that like people get upset by that term. They're like, frail elder, what do you mean? They're like, I'm not frail, right? But so it is basically in the eyes of the state language, it is anybody over the age of 65. So if you basically if you are 65 or older and you also meet that that financial piece, you are eligible for family care, right? So there's that population. Then there is the DD, so developmentally disabled. That's or cognitively, right? And you folks have talked a lot about that.
Yep.
And again, and I know I've listened to obviously I had to do my research, right? I had listened to all your podcasts. So I know that you all have talked about like how it looks different. Like it looks very different for lots of different people, but like somebody DD, like examples, like I'm just thinking on my caseload, like maybe people with Down syndrome or different levels of like autism spectrum, things like that. And then the third one is PD or physically disabled. So that's pretty self-explanatory. Some sort of something or other happened to you physically and you are no longer able to do the kind of typical things, right, with mobility. So that's basically the 3. And then there's mental health, which is not like a separate population per se. In my office, in my unit, when I worked at the MCO, there were social workers that like they were kind of designated, quote unquote, as like mental health social workers. But like everybody has mental health. And it really just depends, right? Like it just, because it could be anything. Like it could be depression, it could be anxiety, it could be schizophrenia, it could be bipolar, and I have supported people with all of those.
Yep.
So I'll stop there. Is there anything that the queens feel that I need to clarify or like questions you have so far?
I don't have any questions.
No?
No,
I
not
don't
yet.
think
You're
so.
covering pretty much.
Yeah.
I'm covering a lot.
I
Yeah.
think one of the ways that we kind of overlap in our knowledge is like we know the other end of the spending.
Yeah.
For sure.
So we have to do something called spend downs.
Yeah, where we
Ah.
spend there's certain amount of money so they don't have too much.
Yeah.
Right.
Yeah,
And so
yeah,
that's where we all kind of work together on that, like the case
Mm-hmm.
team.
Don't go over $2,000.
Right. And also the caregivers.
Mhm.
You know, that's something that we all had to do very often in management.
Yeah. So let me back up just a little bit more. So, okay, like I said, company I worked for, biggest MCO in the state. So every family care member, I should have led with this, but every family care member comes to the program through the ADRC. And so ADRC, Aging Disability Resource Center, every community should have one. That's like part of the ADA, like American with Disabilities Act, right? Yep. So people come and they go there and they literally get the resources that they need, and then they do different screens and they say like, this is what you're eligible for. So every person that comes through Family Care, they get referred through the ADRC. They say you're eligible. They show the scorecards for like the different MCOs that are contracted in that area. So not all 5 MCOs in our particular state are contracted in every county. So like in the county that I was serving, it was like they had a choice between 2. There was 2 different MCOs. And then they like literally show the scorecards and they're like, these are the testimonials and this is what this MCO does versus this one. And then they pick and then they get referred and that's how people would come to us. And so it's a voluntary program. So Family Care is totally somebody's choice. They don't have to be on it. They can be on it as long or as little as they want. So that's how you get somebody. And then for the social work piece, so every Family Care member had a social worker, which is what I did. My title officially was Community Resource Coordinator, but essentially traditional social work functions. So every Family Care member has a social worker and a nurse. And the nurses are called Health and Wellness Coordinators, or HWCs. So, but to simplify that, right, like social worker versus nurse, every Family Care member gets one. It's just part of the package deal. And then the other really big piece of it, so we'll talk more about residential because that's what you all do. But Family Care benefit package is huge. Like, it's massive. And it could range from like residential placement, right? So like, the Family Care, like you get the case managers and they like help coordinate your needs and your appointment. They set services up. They refer you to community things. And also like, again, very super simplified. Like we do all those other things, but at the end of the day, there's like that insurance portion as well. Like they would cover things, right? Like actually fund and pay for those services. So they get them in place, they pay for them. So it could be residential. It could be somebody needs transportation. It could be somebody needs mental health counseling. It could be somebody wants to live in their own home. They don't want to go to a placement. And they need like caregivers to come in. There's agencies that do that. So that was my job, is to set all of those different things up. And where it got really like busy and tricky is, number one, there's a lot of rules because we are tied, like Family Care is Medicaid, and that's like state insurance tied to the legislature. And so like we had a contract with the Department of Health Services. So it's like very high level, and all your stuff is like very dependent on state, and like it's all state funding and contracts. There's a lot of moving parts. Everything you do is tied to tons and tons of paperwork. And that was part of the reason I got a little bit burnt out. But also going back to just that idea, like every member is different. Because remember, there's those 3 target populations, right? And so every member has different needs. They have different desires. And so every time you look at putting a service in place, it has to be really like specific to their need. It is not one size fits all. And you have to do this like line of questioning paperwork. We had to do this thing called a RAD, which stands for Resource Allocation Decision. And so basically it was like paperwork that you did, but you had to like drill down to the core issue of why we were putting services in place in the first place. And they always hammered like responsible stewards of state dollars, right? And so like we always had to be super responsible with that stuff. So like, and we had every social worker, the caseload size approximately at my office was about, I think the target number was like 38, but it usually ended up being more like 40 to 45. And I know I know, right? And there were times that like when I was actually covering and things like that, maybe somebody had left, I was covering somebody else's caseload. There was actually times I covered in like counties like far and far away because they didn't have people. So
well, at least that makes sense on why it would would be feels like everything took forever on our end. Yeah. Because you're doing all these different people. Yeah. And then trying to jump through all these hoops to get it, like, get everything they need or whatever. And we're over here like, when is it going to happen? It's like a month later. We're like, we told it forever ago.
I know. Yeah. And that's why it gets tricky, right? Like, care gets really, really tricky because every person has their team. Like, they have their care team. If they're in a placement, they have their caregivers, right? Somebody might go to mental health counseling, and then they have a counselor that's part of their team. Somebody may go to day services, if we don't know what day
Very
services
common.
is.
Yep.
Yeah,
it's
like
very
folks
common.
that are kind of part of that DD, like cognitively impaired, they go to this thing called day services, which is really awesome. Like, it's a place for those folks to go.
I know, but you still have to find one
You
in
have
the
to find
area
one.
that they're living
Yep,
too, which
yep. And,
also
like,
takes more time.
It does. And like that was the thing, is like working within, so like the company that I worked for, we had like a whole department of people that would like they were like the contracting department essentially, and they would go out and like make the new contracts with the new like providers. But like, so for our entire state of like all the different services we offered, I think there was like over like 5,000 different providers we worked with. That's a lot of contracts. That's a lot of like things to wade through, right? And so you like, you get to learn your own area and like the resources that are available. But like sometimes we would have to place somebody like out of county or something, or somebody was moving, and then the care team would, even though they were moving to a different county, that care team would follow them. So then you had to like look at whatever the resources were, like possible residential placements
Yep.
or day services or whatever they needed, like hours and hours away. But you always had to work within that network, right? You had to find contracted providers within our network to be able
Right.
to cover. So that's part of the reason some of this stuff would take like a really, really long time.
Yeah, because then you have to wait for them to respond too.
Yeah. So like, I guess kind of that tie-in of like how we worked. So Boss Lady Amy and we actually had shared a couple of cases together.
did.
Yeah. So why don't you share your perspective on some of that stuff?
I mean, I guess what do you want to know?
Anything, right?
Yeah, just-
like, what was it like working, you know?
Yeah, like
Well-
when you were dealing with it, just like what did it look from like your side of caregiving?
Well, for one, it was really weird to be working with my sister.
Sorry, I'm so weird.
No, it wasn't you or anything. It was just interesting because, like, you know, this was very different. We had to be professional with each other.
Yeah.
So, like, you know, we couldn't be our normal goofy selves or anything when we had meetings with care teams, or, well, she was part of the care team, or guardians or the
Guardians, yeah.
residents.
Yeah.
And it was kind of funny that her and I ended up sharing clients that both had extremely finicky guardians.
They did.
Mm.
And those, yeah, the two members, and oh, by the way, family care, we call them members. Like some companies say it's like customers or clients or whatever. Like we would call them members. Like, I don't know, you're part of a cool club or something.
Right.
I don't know. But anyway, but yeah, so our members that we had, the two cases, those are my only two people that lived at this particular like residential company. So they lived in the homes that you all worked in, right?
Mhm.
And those guardians, and so it was always like this really delicate balance. So like from my perspective and like, okay, I'll just like be and you know this, like this is not a surprise,
Yeah.
but like the guardians would get pissed off, right? Like the guardians would get like, well, I don't know what's going on over at that house, and like caregiver turnover, and go fix it, right? Like,
know.
you know,
She would call me up sometimes after work and she'd be like, so I had a phone call with so-and-so today. Tell me what the hell is going on over there so I
Yeah.
can fix this.
yeah.
And I'd be like, what do you mean? Nothing's happening.
Well, yeah, and then I'd get an angry phone call about like, well, you know, and the one of our guy that passed away, unfortunately, but that particular guardian, like we always tried to spin it strength-based. We're like, oh, you're such a good advocate for your son. Like you're just, you know, like good job checking in, like letting me know you're such a good advocate, right? So we would always try to do that, but also she was a bit hard-nosed at time, right? Like,
Oh, yes.
I mean, like she would get mad sometimes about, well, you put the wrong shirt on him today, right?
Yeah, it's something.
And then I would
it's
get phone
usually
calls about
something
that.
so simple.
And I would get phone calls about that.
I remember when staff accidentally shaved his mustache.
Oh yeah,
Oh.
she was pretty upset about that.
That
yeah.
was bad.
But like that's the thing is like, so kind of to try to like paint this picture, it's like, so I have this member on my caseload, right? And it's my job to like health and safety needs, right? And like make sure, because then we'd be paying for that placement at the facility. And so it's my job just, to make sure things are going good. And like every, I think it was like every 3 months we had to go do like an in-person face-to-face visit, just see how things are going down at the house, that kind of thing. We would meet every 6 months for care plan reviews. So just like goals, right? And you all have participated in those, right?
Yep.
Yeah. Just
We
make
bring care plans.
you go over the services, you go over the, what their goals are.
BSPs,
Yeah, all of those
the
things.
whole
Change anything that needs to be changed.
That's right.
or-
And not like because it's long-term care, like it's, a lot of times that stuff doesn't change, but like that's all under contract. Like we had to review that and stuff like that. So, oh my gosh. So we would meet every 6 months for these care plan reviews and, I don't know, just make sure, right? Like everyone's kind of on the same page. So, but I like with the way that just like family care kind of is set up, and because there's so many people on your caseload, like it's not like I could go to the house every day, right?
Right.
I'm sure the guardian wanted me to.
Oh, probably.
But it's
For
not like
sure.
I could go to the house every day.
Right.
But then like that's the thing is like, so like where that kind of working together piece comes in is that you are all the staff at the house. And like maybe boss lady Amy is the person I'm talking to, right? Like the contact.
Right.
So I'm not there all the time, but you're my like eyes and ears because you're literally taking care of them. But my company is paying for the placement. But then you also got to make the guardian happy. So it's just like this really tricky balance, right?
Yeah.
Like, and
It
you
re-
see
it
different
really,
things
really
because
is.
you're there day to day. And then I get reports of, I know you all talked on one of your episodes about like, a fall or some sort of behavioral.
Yep.
You got to notify the teams. And then when I would get that, it's like, oh crap, like what happened now?
Right.
Yep.
Then I have to follow up. Maybe if it's severe, like I have to do an incident report. That comes back to all that paperwork piece. But that's how we work together, right?
Yep.
So yeah, do you have?
So one of the things that we did was called bi-weekly updates.
Yeah,
I'm sure you remember those.
I do.
Gross.
I,
Sorry.
So
to be honest with you, that made more work for me because every time I like got one of those emails, like sure, it was nice to know
And
how
then
they
you
were
had to
doing.
enter all that
But then I had to
information.
document it all. And then, like, because of, like, the family care contract, like, there's ridiculously strict rules on, like, if you put in a service or you document something in case notes, you are, like, required by contract to follow back up on that thing. So if it's like, oh, so-and-so had a really nice day bowling, and I document that, I have to check back in, like, a week later and be like, so, is everything still going good with the bowling? Like, and put them like,
that's why I would get those emails.
is that minimal health and safety need? No. So, like, I know the guardians really appreciate that, but that secretly always kind of pissed me off because I was like, because that's another piece, is that we were required to have a minimum of 120 hours of billable time, like, every month. So that literally meant, like, I know you all talked about documentation. Like, that was my life when I worked for family care. But it was like
Document,
literally
it
every
didn't
phone
happen.
call I made, or like if I'm doing case management over emails, and trust me, there was a lot of emails with our
Many.
cases, and every time you had to document that. But like, and so the time you took, like actually taking the call or doing the thing or whatever you were doing, if you were traveling, seeing somebody in person, you counted your travel time, and then the actual time documentation. But like you had to do that for every like member interaction. And so then that would add up, and like throughout the month, the standard was you had to get about 120 hours of like billable time, i.e. like client contact every month. And that burnt me out. And like I know it's necessary, like documentation's so important, but oh my God, like I got so burnt on like literally
That is
charting every little thing I did.
A lot.
It
That
is a lot. Yeah. So it's just, I don't know. What else do you want to like share? Well, like, okay, so I will say, well, we know the one guardian of the one guy, but then the other situation, because he had a lot of falls, and that became a really contentious thing because I'd get the call from the guardian, like be like, oh, like, well, so-and-so had a fall over the weekend, and then I get a report like that. It's my job. I have to go check in. And like, if it's a really bad one, then I may have to go in person. And then I'm getting the pissed off call from the guardian, and then I'm calling you guys, be like, what the hell happened? Like, oh, they're not.
I know, they treat you like it's your fault it happened though. Like it's
Kinda, sorta, like, I don't know, or like, it's more like,
I don't know. Guardians have for us like it's our fault. Like we weren't doing
Oh,
enough.
yeah.
And
Yeah.
there's only so much we can
Yeah.
do. Like I can't force your loved one to like. not fall by like basically locking him in a chair or
Right,
something.
right.
Like,
Yeah. Well, right. Yeah.
And if you want that to happen, then get a seatbelt and make sure it's in the care plan.
Yeah.
right. Well, if they can't do it themselves, then it's a restrictive measure.
Yeah.
Right.
Exactly.
Yeah.
Exactly.
But like a lot of times, so I think a lot of the claims that I got that made it really hard was like, well, they're not following the ISP, right? Like, or whatever. Or like it would be something in our care plan, but it's not documented in the ISP, and like so you have to like all get everybody on the same page and get the documentation to match. But that's what I got a lot of, just like falls and
Right.
like, they're not following what they're supposed to
And
be
I've
doing.
noticed usually, like, then you'll ask about, like, oh, what can we do to, like, better the fall kind of thing? Or
Yeah.
send us an email or whatever.
Yeah.
And then most of the time we respond with, like, we can't really do anything else. He's already got a walker. He's already got, like, grippy socks or,
And
like,
Dad's already
traction
walking with them,
Yeah,
like-
he's
My
got a gate
favorite-
belt on, and we're
my
like, I don't know what else we
favorite
can do.
Right.
My favorite response was something that Jasmine taught me when I was manager at one of the houses. And it was, well, we have everything we need. Like, we can't do anything else. So just tell them, if you have any suggestions, we're very open.
They love that. Yeah. That's true. Yeah, that's really true. But that, and I know you all address that too, is like if there's somebody with a cognitive impairment or like somebody that maybe has dementia or something, like you can remind them or you can try
Right.
to redirect them.
Right.
But at the end of the day, like where it got really tricky because the guardians would say, well, why wasn't somebody with that person the whole time? And then it comes back to the MCO and it's like, well, and so every family care member, let's back up a little bit. Every family care member, part of that functional eligibility to make sure they still have that same level of need is they have to do what's called a long-term care functional screen every year.
Yeah.
So they literally have a screener that comes out at minimum once a year or with a change of condition. So maybe something happened that worsened their health and then they have a higher level of need. But kind of going back to that of like, well, why isn't there somebody with them all the time? Well, their functional screen and their level of need does not indicate that they need to have a one-to-one staffing pattern. And if they don't have a one-to-one staffing pattern and that's not their level of need and it's documented and that's also in the care plan, then the staff did nothing wrong. The staff, right? Like, they're not going to go sit with them every moment of the day because they're not legally required to.
And that's how they determine, like, what stuff would cost also.
Yes,
Is,
we need to talk
if
about
they
that.
need more, if
Yes.
they need more care for
Correct,
something,
correct.
they have to pay more for those services.
So
Yeah.
so let's revisit this like residential thing. So like a big part of my job, obviously not all of my job, because again, members had lots of different varying levels of need and they all have different like wishes and for what they wanted. But one big part of my job was finding residential, searching for residential. And I always told people, especially like if it wasn't just like, oh, we're moving homes, like they're actually going into a residential facility for the first time. I would always say like, it's like the lottery. It's like winning the lottery because it is so hard to find the right fit. Because there's these different types, you all talked about that. There's
The
different
different
levels.
types, yeah.
That's something that people really don't like know. Like they call a nursing home is like a blanket statement for like any type of home. Like that's what a lot of people think it is. But like you all work, your homes are all adult family homes, right?
Some
No,
of
yeah.
them
Yeah.
Okay. So all of those, right? But like basically, I'm trying to like break this down super simply. But like when I was searching for residential, basically we would have 5 different levels of homes. And like that was based on like level of restrictiveness. So typically like a 5 is going to be, that's like the top level of restrictiveness. And that's going to be like a nursing home, or we call them a SNF, a skilled nursing facility. And people don't typically live in SNFs like long term. That's more like
Sniffs.
that's what we would call
That's
it.
really
funny.
ironic because most nursing homes smell so bad.
They
you do not, in
It's
fact,
true.
want to sniff a
Yeah,
nursing
and
No,
home.
you don't want to sniff it.
You
no.
can't, like, get rid of it either.
No.
I don't know what it is. It's like baked in the walls.
Yeah.
But like a lot of times, SNFs are like skilled nursing facilities. They are like, say somebody had a fall, right? Maybe they broke a hip and they are not able to return home yet. They need that like rehabilitation, all of that. skilled nursing facilities are super duper expensive. Like, and I
Yes.
cannot freaking tell you how many people were just like, well, why can't they just stay at the nursing home? And okay, guess what? Sorry, spoiler alert. When you're on state fucking insurance, like, that's not going to happen.
Right.
Like that is almost, that I can almost guarantee you, like, almost 100% of the time, that is never, ever, ever going to be approved. Like, we cannot continue. Like, I know the thing was, if somebody had a fall or rehabilitation, or like if they enrolled in family care while being in a nursing home, we could pay for like 90 days stay, right? Like that, and that was kind of the bare minimum. But then you have to be searching for placement that whole time, right? But so going back to those, like, these different categories, so like every different category based on the level of restrictiveness. So again, that SNF is like the top 5 highest level of restriction, and what they offer, and like what they are licensed for at the state, like that produces basically it was called a rate tool, right? So every facility had a different rate based on those factors. And then the other thing is you throw in what the member's level of need is. So remember I talked about that functional screen. So like it's a really complicated thing. There's like a whole algorithm, but basically like the screener comes in, they do the screen, they have all these different areas that they score on. So like somebody's level of mobility, are they able to, like, they do these different things called like activities of daily living, right? Can they cook food for themselves? Can they bathe themselves? Can they walk around by themselves? All these different things. You do the score, produces this thing, like this score, and like we called it acuity, but essentially it's your score, it's your level of need. So you plug that in with the rate tool, and based on a person's level of need, it came up with the rate band, right?
Okay.
And so like, say we want to go to an adult family home, typically I think your company's homes were usually like 4 or 5, pretty high level of like restrictiveness. And our goal at the MCO, if somebody needed placement, the whole thing was that we always wanted to support independence, like as much independence as possible. What's up? Everything good?
Yeah, it's just my...
I'm reminding her to drink
Oh,
her
you
water.
gotta drink water. So like, you have to like, you get that rate band, like you offer the tool, like, and we could never offer more than what the tool was. Like you plug numbers in and it came up. And so then I'd be like, so say we're searching for placement and I'm like, okay, I have this member. Do you have, number one, they have to have openings. Okay, that doesn't happen quite often. Like a lot of times people are on a waiting list or something.
Yeah.
Right.
So say you have that opening and I say, okay, great. And I'm like, here's the care plan. You hand them the care plan. You're like, read through their needs, right? Like, and then they say, the provider comes back and says, yeah, we could probably support them. Or maybe we can't support them. So then like if they can't support them, maybe they have a really high level of need and the home is not licensed for that, or they don't have staff for that, then like it's dead in the water, right? Then you gotta go somewhere else. Then, so say the magic thing happens, they read through the care plan, they're like, yeah, that looks great. I'll assess them. Cool. Then the provider comes out and does an assessment and says, yeah, we can totally support this person, or no, we can't. Then the next part is if they say, yes, great, we can support them, then I offer them the rate tool based on all those pieces, their level of need, the type of facility that it is. And say it's like, this is super theoretical, but say it's like $100 a day. And I'm like, can you support this person for $100 a day? And they say, yes. And I'm like, yes, that's great. And then you decide when you're going to do the move-in, right? And then there you go. That's successful. A lot of times.
I'm guessing you have to like go back to the whoever's going to be, because do they have to, you would be paying all of it if they were on the state insurance, correct? All the living.
So the members we would pay the daily rate.
Okay.
So that's like the $100 or whatever. And then the members would pay room and board. But
okay, that's what I was wondering about.
Yeah, the members would pay, because like members, and like with the 2000 thing, like think about like people who are maybe like frail elder situation, right? Like, they're retired and they're getting fixed income. Right. So like based on what they're getting, so if somebody's getting like $1,000 a month or something and they're going into residential, like there's this whole other process that they would do, but like they would figure out how much their room and board is going to be. So that's their portion. That's like the rent essentially.
Right.
Okay.
Yeah. So, but then the MCO does pay, like the MCO is like footing the bill, like for the placement at these places, okay. Right?
Yeah.
Yeah. So, but then going back to the, okay, yes, I could support, awesome, but like a lot of times it was, no, I'm sorry, we can't support that person, or we don't support for that rate, right? And then they'd say, well, can you go higher? And then it's like, well, I'm using state insurance, so no. And so that's how it got so tricky. That's why I said it was like residential placement, finding the right fit was like winning the lottery, because so often providers would either decline because we can't support that person's needs, or we just don't agree to the rate. And like providers can do that. That's okay. Like they have businesses to run. We get that. But then that meant me as the social worker, like I might be calling like 100 places, right? And then the other tricky thing is that a lot of times people are like, well, I want local. I want somebody to be local. I want my mom to be up the road from me. And it's like, well, guess what? None of the placements, none of the providers have beds open in this area, right? So we would, and because it's like a state insurance thing, you say like, okay, we'll note your preference. That's great. But we are going to have to look out, and we might have to place somewhere like 3 hours away if that's where the bed opens up, right? So that's why it just got so tricky with residential placement, and how it got really, really hard.
Well, and then sometimes once you find that placement, you have to end up moving them again because they do. When a bed opens up in the area that they originally wanted, then you have to move them. Because that's usually what they want.
I think it makes a lot more sense now why the care teams would always push back so hard when we submitted a 30-day.
I know, and you talked about that, and you guys were all like, it's the MCO's problem. And I'm like, no! And that's when I would come in, and I'm like, fucking damage control. I'm like, what can we do? Let's fix it. Let's do it together.
And it's even worse sometimes because occasionally if we can no longer like do the right support for somebody, or they just don't fit into the house for some reason, if they end up going to the hospital for any reason, homes can like deny them to come back. So then they sit in the hospital until
a bed opens
up somewhere, and then they have to place them.
Can I tell a story about that?
Yeah.
Like real.
Yes.
Are we good on time?
Yeah.
Okay.
We're good.
So I had this one really stuck with me, and it was really, really hard. I know I probably told you about this, but anyway, so I had this guy on my caseload, and he was a very young guy, and like he was part of the children's waiver world, and so he actually came on our program when you can come on like 17 and a half.
Oh, I know what you're talking about.
Yeah. And I just want to clarify that too. Maybe I didn't say that, but Family Care is for adults. It's an adult insurance program for those who are eligible. So you can come on as early as 17 and a half if you qualify, and it could be as old as however. Like I think the oldest lady on my caseload was like 102. But anyway, so any adult, right? So lots of different needs, lots of different things going on. But so I had this guy, he came on my caseload, he was a pre-enroll for me, and he was pretty complicated, like with his needs and stuff. And we finally got around to like when he finally turned 18, we did it, we got all the services in place, it was great. He was living at home, and we thought it was an awesome situation because unfortunately, you all know this, not always do people have supportive families.
Right.
And they don't, unfortunately, they don't want to support them at home, or they don't have capacity, or maybe they work full time and they just can't do it, right? Yeah. So then they go to homes, they go to placements, right? So this person was at home living with his grandmother and a bunch of other family members. And we thought it was awesome. And like grandma was like, she was like a little wily at times. She had a little bit of an edge, but we were like, no, she's right. She's just a good advocate for her person. But then unfortunately it ended up coming out later that the guy was being like severely, like physically, emotionally, like mentally, sexually abused, like terrible. And there was multiple family members that were kind of in the equation, but grandma definitely had like beat him up like a number of times. And we ended up finding out that that she had been like taking all of his like money as well, right? And so he was like,
oh, that happens so much.
It's so goddamn terrible. It's so terrible. So anyway, so we like worked with APS, Adult Protective Services, and that was like an immediate, like, this guy needs, like, they literally went and they, like, removed him from the home on, like, we, like, all this shit, we found everything out on, like, a Friday, like, afternoon, literally at, like, 3 or 4 o'clock.
How did you guys find out?
About
the abuse and stuff.
So, yeah, so it came to us, APS actually contacted us, like, in the county, the Adult Protective Services, and because there was remember the person lived at home with like a lot of family members. So there was like some other random person in the home, like a caregiver or somebody external coming into the home for another family member. And they saw grandma like just whack this kid, like just like straight out, like, yeah. And so that person, they reported that. And because he had just turned 18 and he looked really young, it actually went to CPS, Child Protective Services. And then they ended up, like, they realized, oh no, this kid just turned 18. He's technically has to be served by Adult Protective Services. So they rerouted it. And then as they kind of went in, right, because even if a referral is like screened out, so maybe I need to explain that. But like if you make a call, we're mandated reporters, you see some sort of abuse happening, you are required by your state and your role, like to report it. Correct. And then it goes to either whatever agency, Child Protective or Adult Protective. And then from there, like your job is just to report. You don't decide to do something with it. You just give it to the agency. Then they make a determination if it needs to be screened in. So like further investigated or screened out, like, thank you for letting us know, but we're not going to do anything further with it at this time, right? So they ended up finding out that like this referral was just one of like many like reports that they ended up finding out that like there was something like 20 plus like Child Protective Service referrals, and like nothing had ever been done with any of them, but they were all just like logged in the computer, right? So then APS goes, well, I can't freaking like let that go. She's like, we need to do something with it, right? Yeah. So then they followed up, they contacted us, and they started sharing like what all the other referrals had said, like just financial abuse and physical abuse and sexual abuse and just all these things. And she was like, well, I can't in good conscience like let this kid like stay here, right? Yeah. So anyway, so they like, again, we found it out on like a Friday, and then they were like, well, we can't really do anything over the weekend. But on Monday, like we went into the workday on Monday, like dealing with that situation. And basically Adult Protective Services went at like 3:00 that day and like physically removed that person from the home. Wow. And what we had to do, so our role as the care team is we had to find emergency placement. And so like, and remember, like it takes forever to find placement sometimes, but like in an emergency situation, like there's nothing you can do. He had to be removed. And so anyway, so like
which sucks because then you have to do it multiple times.
Yeah,
it's usually
yeah, and like
you'll go. They can only be at this place for so long, and then they have to go somewhere else, and then you finally found a placement, then they have to move again.
Yeah. Well, we were gonna do a 30-day. The home that we had originally signed up with, like, had agreed to do a 30-day, and like we did all those pieces. We're like, here's the care plan, here's the situation, like, can you agree to the rate? Blah, 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 blah. All of that. Whatever. That was okay. So they removed him. They brought him to this home, local home. And that was the emergency placement. Well, so that was on a Monday. And then, so flash forward the rest of the week, get to the following Friday. He's a kid, his diagnoses were pretty severe cognitively, and so he was he was nonverbal. Well, he could make noises, but like he couldn't articulate words, right? Yeah. So there was that piece, and he would just like hit, and like he was he could be behavioral at times, right? But like, that's number one. I wouldn't
blame him after that.
Well, yeah, because that's what he saw, that's what his family was doing to him. And then number two, he didn't have words. He didn't know how to do that, right? And also he had been removed from his home. So just all around it was a bad situation. Right. But going back to the whole like situation of where they get removed sometimes. So they called. So he was like whacking residents. He was like doing all kinds of things on a Friday night. And they ended up like calling like 911. And so they ended up like shoving him off to the hospital. Like he got picked up. He had to go to the hospital. Basically, they like assessed him and they like stabilized him. I think they maybe gave him some meds or something to calm him down. And possibly Haldol, yep, right. But what Jasmine the Queen said, sometimes they won't accept them back. That's exactly what happened. And they were like, we can't do this. We can't support him, blah, 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 blah. They were pissed off. Apparently, like the head administrator was like screaming at our on-call like social worker. And she was like, we cannot take this person back. So they had no other choice. And like so I was off the clock. This was like the Friday evening. So our company had like always somebody on call. So the on-call person, they were literally at like 8:00 at night. We're like calling crisis beds all around the state. Nobody had an opening. Nobody. And it was just an awful situation because he didn't even have like a mental health need for it. It was just because the other placement didn't want to take him back. Okay, so he did not get accepted back, and he ended up going to this very large, well-known mental institute, and it was just not appropriate. It was not an appropriate place for him to be. And it was very scary. And when somebody is on an MCO, so like that was a Friday, he spent the weekend there. And then we came back the following Monday and they were like, guess what? Your guy is in this place. And when they're on an MCO, like if they have been like cleared, like psychologically cleared, and like the doctors at the place are saying, nope, there's no reason for this person to be here, right? They're not a harm to themselves or anyone else, right? No reason. When they're on an MCO, the MCO basically has to work their ass off to find placement and get them out as soon as possible. And then it starts that whole process over again of like sending out the care plan and explaining the situation and like, looking up the rate tool and offering tools to providers. And it's just, I'm tired just like talking about it.
Yeah,
so
endless.
We've been on the other side of it.
Yeah.
We have all worked with someone that the same thing happened to them.
It's so sad.
It's hard, but I mean at the same time, like it's exactly what our house that we worked at needed. Like,
so you had to say, I'm sorry, we can't accept this person.
Mm-hmm.
I did not have to, but one of the administrators.
But that's what happened.
Yeah.
Did.
Yeah.
But it was more of a mutual thing.
Yeah.
Anyway, because she was her own guardian, and also once she got to the hospital, she was making false abuse claims, which were not true. So the hospital refused to send her back, and it was kind of like a good, well, we're not taking her back sort of thing. So like
But right, like it just illustrates this like super delicate balance of like your roles and like the care team's roles, and like if there is a guardian in place, like it's a lot. Like literally my job, I just said like I'm not even a case manager, like I'm just like a professional firefighter, like literally putting out fires all day long. Like it's just, it's finding that balance and like making sure everybody feels heard, and at the end of the day, like our job was to make sure the members' health and safety needs were being met. And this is a little dark, but we would say this is what made a good day in that job. It was like, 1, is the members' health and safety needs being met? Yes. Number 2, did anybody die today? No. Okay, great. It's a good fucking day. And I know that's dark. I'm sorry, but like that is how it was.
We already talked about dark humor.
Oh,
I just wanted to add though, like, so on your side of things, you guys are supposed to advocate for your people.
Yeah.
But on our side, we have to advocate for
everyone.
everybody. So like the thing you said about him like hitting other residents and stuff, like they have to look at that and be like, okay, well he's hitting other people.
Yeah, especially the ones that like can't
hit
defend
back.
themselves either. So
and I know
like,
that's why it gets so hard, because it's all these different things that you have to balance. And like, yes, I was pissed off that they wouldn't take him back, but also, I understood. And it was just so unfortunate that sometimes that's just how this stuff goes, right?
Mm-hmm.
So
one of the things that we face a lot with care teams is them coming into the homes, just looking around and like judging us and being very rude and looking through all kinds of things they shouldn't be looking
Super
through.
rude.
So
Super
like
rude.
what are your thoughts on that?
I witnessed that because there was that one case I was going to take over, right? Do you remember that?
Yes,
and I didn't take over. I ended up not taking over, but it was a team from like a different part of the state, and I felt like that particular social worker, like, again, it's that, you're doing a great job, you're advocating, like you're really looking out for your person, but at the same token, like personally, I don't like. It takes a village. It takes a village to care for folks, right? Mm-hmm. And like, I don't think that's okay. That's never okay to like treat the caregivers like shit, right? Like, you just, I don't know. I personally try to assume, and like we tried to do this in my unit at work, but sometimes they're really hard days, right? But like assuming the best intent, and just like the caregivers are doing, you have to trust that they're doing the right things,
right?
But like often the guardians are just like, no, they're not doing the right things. So then that's when I would have to follow up and like make sure and re-educate, blah blah blah. But no, that's not okay, right? And I know too, like we do have to get eyes in. Like we were required to go get like actually go do face. And if there was something like bad or whatever going on, or like a report of something, we would have to go into the home and like check things out, right? But like also, like you said before, it's other people's homes too, right? So like that can be really triggering, I think. Yeah. So it's just this really, it's just a hard.
It's a very delicate balance.
It's very delicate.
Yes.
So yeah, and I'm sorry that has happened to all of you, but
I'm going through it right now.
oh, I'm so sorry. Well, and also like another layer of it too, and that's something that like before I left, the MCO that I worked for, they were starting to talk a lot about more, but just like the caregiver shortage, like the caregiver crisis, and like part of I think one of the reasons, at least in my 2 cases with the company. It was because there was lots of caregiver turnover, right?
Yeah.
Like, it's hard work.
Yeah,
like,
because it's like basically you're like retelling every.
You're retelling
to
over things, yeah,
everybody.
all the
It's a new
time. And like,
person again.
the guardians would just get really, really frustrated with that. And it's like, that was one of those moments where it's like, I can listen and like, I can validate your concerns because it does suck. But at the same token, it's like, we can't really control what the company is doing. And like, you can't control other people that are leaving or staying or whatever. So it's like you just have to kind of like weather through it together, you know, and that's hard because it is very difficult work, caregiving, and like not everybody's cut out for it, you know. So.
And that's like part of the reason we started it started the podcast.
Yeah.
Because like we want everybody else to feel as validated as we do doing this, you know. Like now you have a voice.
Yeah, absolutely. So it takes a village.
It really does.
Do you have any closing thoughts?
Oh my gosh, I've been
before we
talking
wrap?
for so long. I don't know if I have closing. I'm just so happy that you guys are doing this. Like seriously, it's amazing that you're doing this, and thank you so much for having me as a guest. I would just throw out there, like just before you come down on your care team or before you come down on your caregivers, just think about the big picture. Like I know that we're only giving high level overview stuff for people, but just think about the big picture and how many moving parts are at play.
Well, thank you for doing this with us.
Oh my gosh,
Yeah,
I had
we
so much
appreciate
fun.
it.
And it's nice to see like a different perspective from
Yeah.
a different like job in healthcare.
Yeah,
So.
absolutely.
I didn't know that you guys had to do incident reports off of our incident reports.
Yeah, I didn't know that either.
Oh,
I thought
yeah.
you could just like upload the file and done.
No.
Yeah.
Oh, no. That's something I didn't even talk about. Like, I know we have to get going, but like, on top of the basic, like, care plans every 6 months and case notes and things like that, depending on a person's situation, like, if there is, like, there was certain criteria that would, like, if somebody, like, a member harmed somebody else or something like that, we had to do an incident report. There were certain criteria. But that was, like, a whole separate form.
Oh,
and then we
God.
would also have to do, in some cases, if the situation warranted it, we had to do, like, risk mitigation worksheets. Like, so somebody is... I don't know. A good example is like, I'm a diabetic individual and I have been educated by my doctor. I probably shouldn't drink like 12 Mountain Dews a day. But guess what? I'm still... Sorry.
No, it's
it just
all
reminded us
You're good.
all of a person.
Yep, all of one person we've all worked with.
Gotcha. But then it's like, well, I don't care. I'm going to do my own thing and I'm
I've
going to do it
had
anyway.
that conversation with her.
So then
We all have.
the care
all of
teams,
us.
the care teams are required also to do like, okay, we sign this risk, like you know the risk of what you're doing. You acknowledge that you know what could happen if you keep doing it. You sign it away. That's your education, and that's so state doesn't come down on you. But yeah, there were so many situations where you might have to do some sort of extra paperwork or something based on that. And again, the business of taking care of people, and especially when they're like tied to like a state funding source, it's very tricky. It's a lot of hoops, a lot of red tape. So again, parting thoughts, just keep that in mind. It is not, and I would say this, I was like who needs to do like extreme adventure sports when you can just like go to work for the government,
I yawned.
essentially. You know, so it's tricky business. So thank your caregivers, thank your care teams.
Well, I think we covered all that we're going to cover in this episode.
Well, bye.
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 This has been the Boss Ravioli Queens podcast with your hosts, Boss Lady Amy,
Nicole Ravioli.
And Jasmine the Queen.
Thank you so much for spilling your ravioli with us.
Don't worry, we'll serve you more next time.
Until next time, go wash your ass.